the All In, All On X podcast. This very official
Episode
podcast. The what?
The Empire Strikes Back. Episode 4 is A New Hope. Episode 5 is The Empire Strikes Back, and every episode 6 it's Return of the Jedi.
Everyone, now you know. All right. Adam Hogan, Juan Gonzalez. Now you know why I have him on here. The ADD in this room is going to be freaking off the charts. We're not going to be able to hold a straight thought the entire time. Right, Juan?
No, I don't think so.
No.
But
I mean,
that's
I've got
okay,
like,
because you know what? That means that we're gonna have to do another one, because it's too many things to talk about that we're gonna need a
yeah,
long time.
I'm having dinner. I'm having Skittles right here. I found these, I was telling you, in my front desk drawer. The girls have room for files and office supplies, but what do I find up there? Every day, drawers and drawers of candy and food. So
Well,
dinner
I
of
just
champions.
drove from Houston. Unfortunately, the clouds were too low, and I don't have my instrument rating yet, so I couldn't fly to Houston. So I ended up, well, I shouldn't call it driving, riding in my Tesla. I hit that autopilot. So 3 hours there, 3 hours back, to just do a simple, it was a patient that had a pterygoid. It was perfectly positioned. I saw the CT, everything perfect, but it didn't take. So I took that one out. Couldn't replace it, but the AP spread was great, so no need to replace it. And then had a posterior mandible implant number 30. For some reason, failed too. And then I took it out and placed another one right next to it. So all is good. But 6
Well,
hours
when you go
total drive for uh, 10, 15 minutes of work.
So when you go all in, X, you got to know how to do revisions. Let me introduce you, my friend, my good friend, Juan Gonzalez. Okay, for those who don't know, and probably nobody doesn't know who you are, but Juan Gonzalez, board certified maxillofacial surgeon, board certified anesthesiologist, I believe, as well,
Well,
in Texas.
board certified in anesthesia with the American Dental Society of Anesthesiology, so something like that.
Okay, still good. One of the developers of the Patsy concept. You guys all know him as the remote anchorage guru. Got a hell of an Instagram page out there. If I still have it pulled up, I don't, but I'll pull it up.
Yeah,
Dr.G.OMS.
unfortunately, my skull collection got pushed down. I need to figure out how to put it like in highlights or something like that, because that's the best part.
Because before I met you, the only thing I knew about this guy, Juan Gonzalez, was he had this kick-ass Instagram page, and it was all CBCTs, 3D algorithm-driven CBCTs, and it was just remote anchorage, remote anchorage, remote anchorage, line by line by line by
Yeah.
line by line. I knew nothing else about you. I did not know until later on that you were actually kind of a cool guy. 50% of the time you're amazing. You're like Sex Panther.
It depends on
100% you work.
who I'm dealing with.
He works 100% of the time, 50% of the time for everybody. Educator, family man, father of 3 daughters, have a wife. And I have to ask you my first question. Is that the reason why you're such a shooting enthusiast?
No, actually it started before I had daughters, and I had my first daughter, and I was like, okay, this might come in handy. And then the second one, I was like, it's probably gonna be a boy, and it was another girl. And then the third one, what are the chances of another girl? Well, it was another girl, and you know what? At that point, I was like, I like girls. I don't have boys. I don't want boys. They're dirty. They're annoying. And then when my daughters are older, there are gonna be plenty of boys around. So I don't need boys right now.
Making a lemonade out of lemons. Maybe, I don't know. But
Absolutely.
you do have a beautiful family. Absolutely, for sure. You get
Thank you.
to spend a lot of time with them. I saw you were out with your daughter this weekend, spending some good time.
Yes, yes. Yesterday I took the little one to SeaWorld. I don't post a lot of stuff that I do with my family, because that's my private life. But every now and then I post something, so to remind people, hey, I also have a family, and I do things with my family, spend time with the family. I try to keep a balance, because I travel so much. I try to make the time count when I'm at home.
Yeah. You do travel a ton. I wonder, like, people say I travel a lot. I mean, you are like off the charts in I know very few people that travel as much as you. What keeps you going in this race for education, or what are you doing?
Oh, and I'm going to slow down, because it's I don't have but I've been traveling about 2, 3 times a week now for the most part of this year, and I need to slow down because I'm getting tired. What motivates me is that when I first started doing remote anchorage and developed the PATSI protocol and all that stuff, uh, patients were being flown to Austin for me to do the surgeries. And I just
Mhm.
didn't think that was right. I was like, why do the patients have to come all the way here where there's other people there that can do what I do? And then I decided, you know what? I want every city in the US to have doctors that can do what I do. And then in turn, I want every city possibly in the world to do what I want to do. So that's how it's grown. And I think that few years later after doing this, there's enough people there. There's a ton of great people there doing courses and teaching, and an outstanding amount of people all over the world uh, doing really good work. So I think it's time that I can slow down and let other people, younger people, continue with this.
I think that's admirable. I mean, I think it's the same way I feel about education. Once I'm retired and gone, who's going to do it? But information and skill set, that's what makes humanity, that's what makes the race amazing is we get to keep building off the knowledge of previous generations, right?
Yeah.
Yeah.
Yeah, and then it all happens, there's too many stories and too many things that too many paths that have led me to where I'm today, and the story's still being written. After residency, when you do residency, when you do any residency, especially a long one like oral surgery, you don't learn from your staff. You learn from your co-residents. The chief resident,
Mhm.
the fourth year teaches the third year, second year, first year. And the first year, you're just absorbing everything. The staff are there to guide you and to help you, but you're
Mhm.
really learning from the residents. So almost every single oral surgeon has the capability of teaching. Now, there's different teaching styles, and some might not be as good. So, uh, when I finished residency and I was in the military, I was just doing uh, procedures. And then once I got out and I started working in private practice, I never thought about teaching. I wanted to teach. And then through a lot of different paths, I ended up getting introduced to the teaching. And even at that point, I refused to teach for 2 years because I was like, you know what? General dentists shouldn't be doing these remote anchorage techniques. They shouldn't be doing zygos. They shouldn't be doing pterygoids. But then I started meeting people like Igor Kaplansky, Raj Sheth, you, Simon O, a lot of people that are GPs and they're doing surgeries that are better than most surgeons that I know because they put the time to learn these techniques, learn how to deal with complications and all that. So at first I thought you were all surgeons, and then I like okay, I guess they can be trainable. So instead of letting somebody else do it, I might as well do it myself because instead of the blind leading the blind, I think I can do a good job at teaching and I've enjoyed it. I met so many great people, so many smart, good surgeons, and I'm talking about GPs, and sometimes every now and then I meet a good periodontist too. But those are far and few.
You love to take the periodontal piss. You crack me
Yeah.
up. You've always got. You ever find any sensitive people out there that just don't get Juan
Oh yeah,
Gonzalez?
but you know what? That's the beauty of it. The type of like when we do a course, it's like for example, full auto and full arches.
Yeah.
It's gonna weed out some some people that probably shouldn't be there. Same thing with ways of the arches. So yeah, sometimes you get with sensitive people, but if we're in this field at some point, you have to develop tough skin, and that's how he was in the military, and that's how he was in residency. And if you don't have tough skin, you're not going to survive. So yeah, every now and then I meet somebody, but they know. I'm saying it joking. I have plenty of periodontists friends. They're good people. They're good friends. And you can ask Maurice Salama is one. A combination of a periodontist and an oral surgeon in an office, it's a really good combination because we kind of like complement each other. The way like the stuff we don't want to do, we just give it to the periodontist. I'm joking there, but
Yeah.
no,
No, but
Salama is
it's
something
true.
that Mason and I discussed that a few years ago. How he's got Aberdeen, super nice surgeon, and the two of them work together so well. So I think if possible, and you'll have a good, if you join forces instead of competing with each other. If you're in a town and you have a good friend that's a perio or an oral surgeon, hey, approach it and talk about it because it's a really good, powerful combination.
Oh, yeah, absolutely. Man, you said so much there that I want to go back to. The military, having to have tough skin and a good sense of humor, I think goes with that. And then combining forces with people that do things that you don't do or don't want to do or don't know how to do or whatever.
Mm.
I think that those are three vital lessons. I mean, I'm expanding here and trying to put all that stuff into my office here at Full Implant Choice. I want to go to your military roots because I get you, Juan. I mean, I'm a United States Marine, U.S. Army. We're brothers. We get what it's like going
Army,
through tough
Army, and
times.
Air Force. Don't forget, I did Air Force too.
What's your greatest love?
Well, I spent 12 years in the army. I spent more time, and I was active duty in the army. So
Mhm,
most of my memories are from the army, and then but I have really good memories from the chair force. And the chair force, it's just totally different. And what I tell people is this: what do you want for if you're planning on joining the military? What do you want to do? If you want to have it really nice and really good, it's Air Force first, then Navy, then Army, then Marines. Now, if you just want to go kill and fight, then flip them over, and
yeah.
then that's your military branches for you. So I had no idea. I would Nobody in my family has been part of the military, and
Mhm,
I had just finished dental school. Actually, no, I was still in dental school. I was doing a month with the oral surgery department in Puerto Rico, where I went to dental school. And then I met this guy. He was in the army, and he was with the oral surgeons. So
mhm.
he was a Mormon guy, and he spoke perfect Spanish while he was there. And he told me, "Oh no, I'm in the army." And he explained the whole thing. I said, "Why are you in the army?" He said, "Because they have good training opportunities." So fast forward a few years, I graduated from dental school. Then I did a 1 year GPR. Then after that GPR, I applied to oral surgery in Puerto Rico, but it was very political. And I was a runner up. And that's a long story for another day.
It's always political. Yeah.
Yeah, and then, so I started looking for options, and then I remembered that guy from the army. So I called the army recruiter, I called the Air Force recruiter, and the army recruiter immediately called me back, and I told him, "I wanna know how many people apply in the army to oral surgery and how many get accepted." Okay, next day he was at the office with that. I asked the same thing to the Air Force guy. He's like, "Oh, come back here to our office in a week." So I
Mhm,
found out that they were better, the chances were better in the army. And I
yeah.
figure, it's the army, it's not the best and greatest. So I'm sure I can compete with those guys. Now, the Air Force, those are the smartest ones. So that's going to be harder competition. So I played the game of probabilities, went with the army, and that's where I did my residency.
I love it. Oh, yeah.
Well,
Well, you
12
gotta
years active duty. Those 12 years, it was 2 years because at that point I had to wait. I couldn't start right away back
mm,
then. So I had to wait 2 years to start residency. Well, 1 year to apply, then 1 year to start, then 4 years of oral surgery, and then the payback for all those 4 years plus 2 other years. Ended up 12 years active duty army, and I lots of memories from those days. And then I got out, had a break in service for 2 years, and I decided, you know what? I don't want to lose all this time. So I went into the Air Force Reserves so I could finish my time. And I did 8 years of Air Force Reserves.
I gotta commend you for the years you put in. 20 years, 12 and 8, that's a long time. I mean, I did 4 years in the Marine Corps. A lot of people I don't always say this, but after college and dental school, I did 3 years in the Navy as a dentist. I'm like you, I always claimed the Marine Corps as my first love, but the Navy was fun. I had some good times. I have good friends there, but, it was just completely different. It's what do you wanna do? You have to learn, well, let me put it this way. You were born in Spain, grew up in Puerto Rico. Did you always have thick skin, or is that something that the military sort of helped embed in you?
I think actually I think it was residency.
Mhm.
I think it was residency that my wife will tell you that after residency she was like, "No, you're not the same person that I married," because it you go through a lot in residency. I mean, uh, people watch stupid shows like Grey's Anatomy, that's a soap opera,
Yeah.
and I couldn't stand that show. But
Right.
then I watched a show like Scrubs, and I think Scrubs was like one of the most realistic shows of life in the hospital, and the things you go hierarchy with the residents, the relationships with the other doctors, other services, the nurses. But you have to develop when you show up there on first day. And I'm sure that now they're a lot they're not as heavy as they used to be. We had to work. We would put in 14-hour days, 16-hour days, and there was no control on the hours. And I think
Yeah.
that controlling the hours is a good thing because I remember doing my general surgery rotation, and one day I had been off for 42 hours, and I couldn't enter a prescription. My brain could not process me writing this prescription. So
Right.
one of the it was the time to leave, and one of the other residents said, "Hey, I already entered. Go back." And then straight from there, I go to this conference room to listen to this talk. And
Right.
I all I remember is I sit there, and then somebody wakes me up. Hey, it's over. Time to go home.
Yeah.
So the hours were my first week in there, and I'm doing a surgery with my program director, and I'm taking out wisdom teeth. And I was really good. I'm still are, but I was starting residency. I was really, really good at taking out wisdom teeth. I
Mhm.
started doing them with my co-residents, even my chief, and I would smoke them. I was really good at that. But then I sit with my program director. He asked me to present the case, and then he sits to assist me. First thing he says to me is like, "Why are you grabbing that instrument like that?"
Right.
And I start telling, and he's like, "I know you have an opinion. I just don't want to hear it." So I'm stressed. I do the case. The case goes great. And he was quiet during the case. He like he criticized me for like minor things, and but I feel like shit. I feel like this guy that destroyed me. And then he walks out when I'm done after I put the last suture, and the assistant tells me, "You did really good." I'm like, "What do you mean?" This guy was like yelling at me and telling me this. My wife, even at that point, she decided, "Oh, I might go visit him." So she walks out of the room, and I went like this, and I look at her, and she immediately left. And when I got home, she said, "Oh, when I look at you, it looked like you wanted to cry." I was
Yeah.
like, "Well, this guy, he treated me." But the assistant said, "You did really well." And I'm like, he was yelling at me the whole time. She said, "He never took the instruments from your hands."
Oh, yeah.
And she also, after that, he never ever sat again with me to do a case. I would
Nice.
go present the case and tell him, "Oh, this is what I'm doing." He would look at the answer, "Yeah, go do it." So that told me that after he saw that, but he had to give me shit. On the first day, he cannot praise me or say anything because he cannot let me start like this high. They break you. They break you. They bring you down, and then slowly over time, if you earn it, then you get built back up.
It's funny. I did my GPR, Portsmouth Naval Hospital, is 2000, was it 2, 3, 3, 4? It's basically, I call it the 0 year oral surgery residency. It's the scut year. You're below the first years. All they really want to do in that
Mhm.
program is get you to go into oral surgery. They have the other disciplines. You barely talk about perio, endo, whatever. And you round with the oral surgery. You're doing oral surgery all day. It's always like a lot of orthodontic surgery, a lot of whizzies, not a lot of trauma. It's a on base hospital. But I remember being there and you're just getting yelled at left and right and left and right and all the time. And I'm a former Marine. I remember looking at the chief one day and be like, I can understand you yelling at me when I do something wrong or when you told me what to do and I know I should know how to do it. But you're yelling at me for stuff that nobody's even told me before, you know? And he's like, look, and he brings me in the room. He closes the door. He's like, look, it's just something we got to fucking do. Okay. He's like, everybody's gonna yell at. Shit rolls downhill. We're all gonna yell at. You're at the bottom. So when we're out there, basically in front of the attendings and everybody, you're gonna get yelled at. Just get used to it. Just play the game. I was like, okay, that's fine. I think it's good man, ready, oral surgeon out there in Texas, I believe now. But nice guy. At least I knew he was back then, 20 some years ago. But I know a little bit about what you're talking about, and I know a little bit about staying up. What year was that, by the way? Because we went through this thing in 2003 where all of a sudden they came through and said that you're not supposed to work 20 hours a day, 30 days
Yeah,
a month.
I think it was something like 75 hours a week. You couldn't go over 75 hours a week.
Was that around 2003? Was that around that time?
Somewhere around there, man. I can't remember
Yeah.
because I Yeah, my I started residency in 2002, graduated 2006, and I think it was around that time that they said that. But they told you, okay, we would all lie because it was impossible. We couldn't do all that work in 75
No,
hours. And
no,
of course, you don't want to be the guy that's going to report them or do that. Back then, you
right,
just put up with it and you just did
yeah,
your
yeah.
job. You went, did work, and then go home.
Yeah, because there's some act of Congress coming down saying you can't work more than 75 hours a week, and there's not a lot of help there, and there's a lot of patients, and, the
Well, in that
faculty and
case,
attending aren't gonna stay all night.
yeah, well, in that case, what they had shown in studies was that there were a lot of errors being made
Yep, that's
because
right.
of the hours being put on the residents, and a lot of medical errors were being made. So that's why they changed that.
Yeah, let's bring that to real life, all in, all on X. How important is a good night's sleep
Oh yeah, no,
for a
it's.
procedure?
I mean, how have I unfortunately in the past, a couple of times in a foreign country while teaching, have
Yeah,
I stayed up night to then do surgery next day? Yes, and frankly, when I'm doing in the surgery, I'm in the zone. I don't feel it, and it doesn't really affect the performance. It's when I'm done with the surgery that I feel it. It's like then I feel tired. Is that every time I go into surgery, that surge of adrenaline wakes me up, and I get in the zone. I
yeah,
turn into and people that have been in the OR with me know that I turn into a different person, I'm not nice one. I'm surgeon one, and just have to get done with everything as best as I can. And I like for things to keep moving. My assistants have 3 seconds to give me what I need. They don't give it to me in 3 seconds. I move to something else. But it's constantly moving. You have to constantly moving. I can't stand when people just stand there just waiting for something. No, there's always something to do.
yeah. You, definitely challenge my surgical techs here when you come to the institute when we operate, which we'll be doing in December, by the way. Remote anchorage is in 4 weeks. We're gonna be here December 12th or something. But my techs, they respect and love the hell out of you, but they're always like, they're so nervous that they're not gonna be fast enough. I don't know, are they doing halfway decent job?
No, they do. If I remember, that means they did a bad job. And I don't remember having any hiccups because the other thing is like the advantage or disadvantage, you can say when teaching, you have to slow things down
Yeah.
because I have to talk. So that gives them more time to give me what I need because I'm talking and I'm describing everything I'm doing. So that gives them a little bit of a break.
Yeah, bringing that up, watching you teach, surgery, you know, um, it I love the way you explain surgery because I mean, I've been around a lot of doctors explaining surgery, and I think I'm maybe I try to be on par with you because you take the time to explain all the little things that you do. When I see other doctors teaching surgery, they're just doing something and bam, they're done, and people are like and it's like, "Did
Um,
you see that? He just put in the zygo."
I
Did you
I
see that?"
see I see that, I'm lucky enough to be involved in a lot of places that I go teach in every aspect of it. Model surgery, live surgery, cadaver surgery, one-on-one surgery. So I do it all. And luckily I can learn also from other people. We all learn from
Yeah,
each other. So unfortunately also I see sometimes people teaching but they're not very effective at teaching because for example, when I'm doing the live patient, not that I'm doing the live patient, when the person that's coming to do the course is doing a live surgery course, I'm gonna walk in and I'm gonna tell you start, and you're gonna start, and I'm gonna watch you. And if I see you doing something that might be wrong, I might at first guide you. But then after that, I'm gonna watch you, and I see you that you're about to do something. I tell you, this is what you're about to do, and then you mess it up anyhow and then I show you, okay, let me show you how to fix it. Because if I do and you watch me work, you learn nothing. Now, if it's something that could put the patient in danger, or if it's something that, like if you're going to put the drill in the orbit, yeah, I'm going to stop you before you do that. Okay. But if it's something and that's why I have you use pilot drills, I let you mess up with the pilot drills and before you screw up the osteotomy. But I
mhm,
let people make the mistakes and then tell them because too many people, you're paying a lot of money to learn. You're not paying to watch me do surgery unless it's one of those that I'm doing the live patient. You're just watching.
Right.
If you're doing, you're doing.
Yeah. That brings me to a story how you kind of let people screw it up where it's not like a critical moment. I get that. And I was watching you work one day. I was remote. I was watching you on closed circuit television in another room, and you were on the loudspeaker in the auditorium, and there was a picture of the mouth. We could just see what was going on up close, 4K, and we could hear all the voices. We could hear you in there, and the resident said, you were like, "Oh, stop that," or whatever, and the resident said, "Oh, the instrument did this or slipped or did that," and you just, without skipping a beat, you said, "No, the instrument did nothing but did exactly what you made it do. The truth is you fucked it up, but it's okay. We're going to fix it now." And you just, without missing a beat, and you said, "We're just going to fix it now because that's how you learn." And you didn't condescend, you didn't put him down, but you hit that truthfulness, that hard truthfulness that aspiring surgeons and doctors need to hear. They always want to put the blame off on the instrument or the assistant or the implant or the patient wasn't compliant. But you just hit them softly right between the eyes. It's not the patient, it's not your assistant, it's not the instrument. You screwed it up, but it's okay. That's how we learn.
Yeah, and that's how you learn. That's how we all learn. I learn from watching other people do surgery. I learn from going to courses, all that stuff. But I also learn every time I have to fit something that somebody screws up, and we all learn. And so we all learn from each other. So the minute anybody says, "Oh, I'm done learning," "Oh, I don't have anything to learn," then you learn nothing. We always learn it. The techniques change, things get improved. I always tell this story when I give the courses, and it's like the first person that contacted me through Instagram, Keenan Osman from Florida. He sends me a message, "Hey, I want to come shadow," and I don't know who the hell he is. I just started posting stuff on Instagram, so I sent him my phone number. Here, call me because I don't like typing. I prefer to call. So he calls me. And he said, "Oh, I want to come and shadow you." "Oh yeah, sure, whatever. Come. How much is it? Nothing. I'm just come and hang out for the surgery." So then I look him up, and when I look him up, I see this mouth condom thing in the mouth. And I go back to the clinic and I ask my restorative dentist, Dr. Emery, Sarah Emery, "Hey, Sarah, what is this mouth condom thing?" And she's like, "Oh, that's an Optrogate. We have them in the clinic." "Oh, really?" So I put that in the patient's mouth and I tested it and I fell in love with it. I said, I do not ever want to do surgery without this thing in the patient's mouth. So the first person that was coming to learn from me taught me something. So
Yeah,
that's how this works.
absolutely. One of the greatest intangible benefits of educating is you get to learn something from people around you. When 20 doctors come in our room, all 20 of them have something to teach me, just like I'm teaching them something. Or you hone your skills. Iron sharpens iron, as they say, right? Got to ask you, since you are board certified maxillofacial surgeon and educator, have you ever had an implant not integrate?
Never. They all, but if I look at an implant, touch it, and blessing it, and it will not fail. No, of course, everybody, that's like the people that say, "Oh, I've never broken a root taking out a tooth." Because you're not taking enough roots. You're not taking enough teeth. If you're going to drive, you're going to have complications. You're going to have an accident. If you're going to do surgery, you're going to have complications. You don't want complications, don't do surgery. You don't want accidents, don't drive. It's
Yeah.
gonna happen. And now, what sets you apart is minimizing and avoiding and knowing how to treat, because some things you cannot avoid. Like I look at those two implants today. So that pterygoid implant, why did it fail? Have no idea. Shit happens. So it was I look at the CT, perfectly positioned, everything great. Uh, when I look at the mandibular one, it's a posterior. It was 5 by 8 millimeter implant, but the lady has florid ulcers dysplasia. Could that have contributed to it? Maybe, because the
Mhm.
bone there had that mid appearance. It had every implant that I place has good torque. If I place an implant and it doesn't have good torque, I change that implant or I take it out, I put a wider or longer, whatever. So there's never a question in my head, did that implant have torque? Because I always place implants
Yeah.
with good torque. Well, it happens.
Let's define good torque for the audience. What is good torque?
For me, good torque, it's at least like 45. That's
Yeah.
for me. But I know all the studies show it's 32 is the optimal. And if you're doing all on four, and
Yeah.
you have something in front of it that is like 50 and another one that is 50, and in the middle you have a 25. I in the past left an implant at 25. Yeah, in the past I've done it. But ever since I started getting better torque, and not excessive torque, I'm not talking about 60, 80, or something like that. And every time, and understand that every time we show pictures of an implant with a lot of torque, is because we've gone in and out, expanded that bone. So when we stop, it might show that high torque, but it's not that we kept going. If you, like I always say when I teach, if you start going past 50, you need to either uh, uh, make the osteotomy bigger, go in and out if you're almost done, or or take out the implant and make the osteotomy bigger. Because if not, you're gonna break the implant, you're gonna break the driver, or you're gonna break the bone, but something is
Yeah.
gonna break.
Well, I mean, I have a slightly different approach to that. I go for 60 on all of my implants, and I do self tap with the implant frequently. I just more take my time. I've been in those situations where you're in dense bone, you can't get the implant in, you take one drill bigger out, you put it, one drill larger in the osteotomy. You go back from I can't seat the implant to I almost have a spinner or 25. So I'm more, and I like to teach young people, take your time, take your time. Not
Yeah.
everybody is Juan Gonzalez. Nothing wrong with what you're doing, but I mean, I frequently get 60 newtons on everything. There was a Facebook post, and I know 32, 34, that's like the minimum torque in the
That's
literature,
a
I guess.
minimum for me. That's a
Right.
minimum, but I rarely leave an implant with that low torque. I mean, if I have like some strong ones next to it, but I like torque, not excessive torque, but good torque.
Yeah. You shouldn't, for the listeners out there, never over 100, shouldn't be pushing more than 80. But I like to kind of get it where I know it's a good solid 60. I feel good. There was just a Facebook post. This guy wrote, um, you know, we got great torque on all of these implants, 30 to 40. And I went, like, hey, that's acceptable clinically minimum, I guess. But we can help you get. I'd send him a DM. I'm like, we can help you get better torque on your implants because you're in a bit of a hairy situation. Because
Yeah,
pterygoid
if that's consistent, and they're not under prepping enough. I call it holes and screws. All you have to do is just show me the implant. I look at the implant. If I look at the implant, then I know what type of hole to make for that
Yeah,
implant. And then I always start with a pilot. The pilot gives me that sense. Okay, this bone feels hard, feels soft. Then once
yeah,
you drill, you take the drill out. Look at it. How does the bone look? Does it look like white burnt bone, or just white, pure white bone? Does it look like soft bone, a red bone, marrow? So you look at your drills, feel and look at your drills, and you get all the info that you need.
that's right. Do you have any experience as a kid or in any other professions? Did you have you ever built or framed houses or anything, farmed or anything?
Oh, I build all kinds of stuff. I build all kinds of shit.
Yeah, yeah, yeah.
I'm from scratch too. I actually, when I was on the phone with Melanie and Wyatt earlier, I was going to get my dog from the backyard, and we were on a video call. So I showed them a table and some chairs that are back there that I use for parties that I built. But I've built a lot of stuff.
Yeah. Do you think that doctors who are in dentistry as a second profession or that they have hobbies like building and things, that they have better hand skills and make better implant surgeons?
I think so, because you also have that builder's mind and how to troubleshoot things. My father-in-law would get upset at me because he would come to the house one day and he would see chrome molding done on a room. He's like, "Oh, that's nice chrome molding. Who did it?" I said, "I did it." He's like, "Where did you learn where to do that?" I looked it up online.
Yeah,
And then, when you start doing it, you buy the tools that you need for it, you start doing stuff, then you start running into problems, and then you have to figure out how to solve those problems, and that's
yeah.
that's how you learn.
And for those listeners out there who are beginner implant doctors, AOX doctors, beginner surgeons, whatever, and you think you just went high school to college to whatever residency, it's not too late. Go to the Lowe's, the Home Depot, get a bunch of different wood, get a bucket of screws and a drill, and get some hand skills. It's not too late, I would say.
Yeah,
Put some
when I
things
compare
together.
yeah, when I compare implants, I'm talking to in one day I'm talking to this implant company, and I'm telling them, you got your implants backwards. No,
Oh,
no, not
yeah.
this one, a different one.
Okay.
I'm talking to a different company, and I'm like, "You got your implants backwards," and they're like, "What do you mean?" I'm like, "Your wide implant, it's the metal screw. Your thin
Yeah.
implant is the wood screw." So they didn't understand what I was saying. I'm like, if you look at a metal screw, it has a lot of
Yeah.
threads close together and
Mellow
small.
pitch. Yep.
That's because you're using it for a metal screw. Now, when you're using wood, it has wider threads and sharper and further apart. And then they realize, oh, we've made it backwards because they made their fat metal screw. They made it for dense bone, and that doesn't make any sense.
Mm-hmm. I
Actually,
think
no,
if
the opposite. They made their fat metal screw for soft bone, while it should have been the one with the bigger threads.
I've seen the same
They
thing, my
would,
friend.
yeah, but
It's like there's isn't it true that I think early on most dental instruments were built by farmers and carpenters? Isn't that right? I believe. I don't know. Have you heard that? I thought they all had this history of coming from that. Anyway, tell me something as an expert in the field. Um, what are the biggest surgical and prosthetic mistakes the most common mistakes you see being made?
surgical, probably the biggest mistake, most common when doing an FP3, not doing enough bone reduction. That's number one. Second, soft tissue, not knowing how to handle soft tissue, and
Hmm.
not keeping enough keratinized gingiva when you design the flap, the suturing. That's probably the biggest mistake. Prosthetically, oh, there's plenty more. You can still do the surgery perfect and screw it prosthetically. Prosthetically, I had to learn the pros because when I started doing this, there was no 3D workflow. So I
Hmm.
was picking up everything. And I didn't have a prosthodontist or a restorative dentist. I had to do it myself for the first about 3 years I was doing full arch. I was doing all my pickups, but I applied all the concepts that I learned from orthodontic surgery. And to me, it was like I was positioning that maxilla,
Yeah.
picking up the implants. Then after I started with the cylinders, which I hated because it destroyed the occlusion and it had to be rebuilt, and I hate adjusting occlusion. So that's a second mistake that I see. Besides not picking up the positions correctly, uh, not picking the right multi-unit abutments, making prostheses that are either too thin or too thick, and then not adjusting the occlusion properly. And then now you have forces that will destroy your implant. So now with the 3D workflow, I think that before you start doing 3D workflow, you should do a few cases. When Sammy, Dr. Ponusami, came to work at the Austin clinic, I challenged him and I said, "Hey, I want you to do the first 10 to 20 cases, you do the pickups yourself." Because
Yeah.
back then we were still doing pickups. And then we have a restorative dentist that she would come and do them. But I challenged him, do them yourself. Well, do you know what? After he did 10, 20, he did them all until
Yeah.
we jump into the full digital. Then after doing full digital, neither him nor I did pickups anymore. But I think there's if you learn analog, it will make you understand the position of the multi-unit abutments better. You're going to have better access hole, and it's going to make you a better surgeon learning the pros, which is my main criticism of most oral surgeons that get into full arch. They don't learn the pros.
Right, right. I'm going to piggyback, and I'm also going to promo really quick. Our January course coming up is Module 1. It's boot camp, core boot camp fundamentals. So we made it a point to teach analog conversion there. Why? I mean, I'm a full implant choice, 100% fully digital office. But why did I decide to do analog in Module 1? Because exactly what you said. If you don't know how to do this, it makes the digital steps so much harder to do. You have to understand the prosthetics. Your surgery sets the tone for your prosthetics, but that first prosthetic you do sets the tone for all future revisions or until final. And it's hard to go backwards if you don't do the previous step correctly. So, surgeons, it's not enough just to, well, I picked up the denture and I sent it over. I mean, there's a lot of technique that goes into that you need to be aware of. I honestly think, Juan, at our age, I feel, 50 some going on, age 13 and a half myself. But honestly feel like we have an advantage that we came up with having to learn how to wax dentures and pour impressions and articulate models. I really feel that the younger doctor is kind of it's hard to catch up in a completely digital cyberspace. How do you
Mhm.
feel about that?
No, it's the same thing because when I was doing or when I learned orthodontic surgery, I had to put a face bow on the patient, get impressions. Then I had to mount them on the articulator. I had to make lines on them, cut that maxilla, reposition the maxilla by waxing it. Then I had to make the spline, put holes in the spline. I mean, all that stuff, and it was all done by the resident. And then sometimes if you made the splint too thin, when you show it to your staff, they will go like this and break it. Oh,
Hmm.
tough luck. You have to do it all again.
Yeah.
So, a lot of learning back then. And but now the last orthodontic surgeries that I did were a few years ago. I planned them one while I was driving, the other one while I was taking wisdom teeth out because it was all digital. So you're looking at the screen and you tell them, move it here, move it there. Now it's gotten to the point that you plan everything digital. They send you a cutting guide and they send you custom bend made plates.
Yep.
So it's a lot easier. I understand that. But I think there's also, like you said, that the value of learning the analog. Same thing with guides. Let's talk about guided. Uh, I think guides have a value. And I'm talking about full arch, not single implant. For single implants, I
Hmm.
really don't do single implants anymore. And if I do them, or if I would do them, I'll probably do them all guided, whether static or dynamic or Yomi or whatever, or EdSnav. I think I would do them because a single implant you'd require 100% precision or 99% precision. For full arch, you don't require as much precision. So I think guides are good maybe to start learning the basics and positions, but you cannot depend on a guide. It's like training wheels on your bicycle. And
Yeah.
then once you run into a problem with the guide, if you don't know how to solve it, you're
Yeah.
screwed. The patient is going to go home without teeth. Now, if you master the procedure and you're using guides, what's going to happen is you're going to realize, I'm spending all this money on the guide and all this time it's slowing me down, and then you stop using them, just like your training wheels on a bicycle.
Yeah. You know, case in point, I think 2012, I started. I thought if I'm really going to get into a lot of this full arch stuff, I'm going to do it guided. I felt like it was a responsible thing to do. Blue Sky Bio, Blue Sky Plan was available. Um, no endorsement of them. I don't work with them right now. Good people though. But I was planning all my guides in Blue Sky Plan, and I was creating them and I was 3D printing them in my office. I learned a ton about anatomy and all on X doing that. But more and more, I found myself not following my guides. You would see something in the digital workflow and you go, well, that's the place for the implant. And then you look in the mouth, you go, it's better over here. And then your guide, I made my own. It cost me a lot of time, but not money. But if you're one of those people that are spending $5,000 on this guide setup, and then you don't want to follow one of the implants or you don't know any better. So anyway, more to your point, I think that you can become an excellent doctor by going through those steps, but you got to know what to do when you're not, you know, when you don't have a guide or when it doesn't work. As the years went on, I started just leaving them all on the table and I just stopped doing them altogether. But I thought it was a good learning tool to begin with. My first case that I had with an area prosthodontist, I tried to get this prosthodontist to refer to me for years. I couldn't get the time of the day, and then he kind of got interested. And I said, "Let me do it all on X. I'm going to guide it." And he was in the room, and I said, and we were over here in like the 12 site, 13 site, and I looked at him, and the guide's all in, and I'm nervous because I want referrals from this pros, and I said, "Hey, that doesn't quite look right, does it?" And he's like, no, doesn't. I'm like, permission to take the guide out. And we got a much better implant. And we went back to the computer and we both agreed that we thought the original plan was the best place. But
Yeah.
you have to know when to pivot and when you can't go with that, right? You got to know when to call an audible. Tell me, 20, you've been 20 years in full arch?
No, I've actually not been in Fuller's that long.
Okay. Oh, really? You wrote
Yeah.
Patsy 4 years ago, 5 years ago?
Yeah, about five. Yeah, about 5 years ago. I
Yeah.
was so anybody that has taken the course uh any courses that I've given have heard the story, but the long story short is that I started recognizing after I learned how to do pterygoids and zygotes and all that stuff. I started recognizing a pattern that I was always following. I was always following this pattern: back, front, middle, back, front, middle. And I always had this pattern. So I was trying to come up with a name for it. And I was about to teach my first course in Dallas. And when I was there in Dallas the night before, I was at the bar and I was finishing a presentation, and then it was right there in front of me, the name. I
Right.
started back then when I started, the P was for pterygoid, and the A for anterior, the T for tilted, and the Z for zygomatic, and the I for implant. But
Mhm.
now it has evolved and I have changed it. And the P also includes PSI, so patient specific implant, a
Wow.
superosteal. So if you
Oh,
start the case and you determine, oh, this case has no bone for anything, I cannot even do zygotes. Hey, is might be a PSI, the first option. And then the P now is more posterior, because posterior will include a pterygoid, also palatal root implant. Some people out there, they like to do, instead of doing a pterygoid, they like to put a palatal root implant. Unfortunately, I don't have patients that have bone there.
yeah.
And if that doesn't work, we're talking about the posterior inferior zygomatic implant. Those usually are going to be your most posterior implant. If you want to have best AP spread, then you move to the front. In the front, there's all kinds of techniques in the anterior, and then in the middle, you have your tilted, you have your transinus palatal approach, and if none of that works, then you have your zygomatic.
Yeah. I love acronyms, military guy. If it has an acronym, it must work, right?
But to
And
me, it was
everything needs
it
an
was
acronym.
more than an acronym, because it's something that it's a workflow that you can follow. And if you follow it, every single person that when I first started teaching it, I had one of the first people that came were Steven Nelson and David Bulow, which are great friends of mine now, and they were some of the first to learn the Patsy, and they went back to Louisiana and they called me and said, "Dude, this works."
Yeah.
And of course it works. I've been using it now for a couple of years. It's just I didn't have a name for it, and I just had a pattern that I was doing.
Yeah. Yeah, you did influence my life because before you, Terragoid was something I did when I thought I had exceptionally long cantilever. Like I've got a 3-tooth cantilever, a 2.5 tooth cantilever. Okay, now I might have to do a Terragoid. And you said, who gets a Terragoid? Everybody gets a Terragoid.
Everyone. Yeah, but
And
why not? It's like I still want somebody to give me a good reason not to do pterygoids. The only reason I can that's not bullshit. Yeah, of course, a lot of people say bullshit excuses. Oh, it's a difficult implant, nonsense. It's a dangerous implant, nonsense. Oh, it's difficult to restore, nonsense. Oh, it's just too far back, and the patient's gag, nonsense. Oh, it's too hard to clean back there. All this stuff is bullshit. It's the only real reason not to do it is because you couldn't do it. A patient, maybe you don't have good technique, maybe
yeah.
the patients had soft bone.
That's
That's pretty
more
much
reason
it.
to do
Or
that's more reason to do it. Because the
yeah, the
Terragoid
patient the
becomes the
patient
best.
the patient might have limited mouth opening. Yeah, I'll buy that one. But when I get them
Yeah,
99.6% of the time, that tells you that. And it why not? If it might help that was avoided a zygo, it might help save that tilted implant. It helps with eliminate cantilevers, AP
yeah.
spread. I mean, too many positives to not do it.
Way too many positives. I'll agree with you on that. We're going to talk more about that. Shameless plug in December for Module 3. But we're going to talk a lot about it. And you got to come because it's not just as simple as knowing the order you put the implants in. I mean, there's a lot of fine details
No,
involved.
there's a lot of stuff
Yeah,
to there's a lot of stuff to consider, but mastering, when you master all the techniques, is just you just have all these tools available,
yeah,
which also it's all the little things, and one of the important things is implant selection too.
hmm,
There's all kinds of implants. There's short, long, big threads, small threads, tapered implants. So implant selection for what you're trying to do, that's one of the reasons why for many years I refused to sell myself to any implant company. And I lecture and I did a conference for most of the big ones until I finally felt like I found a home with SIN, because
yeah,
they have all the implants that I'm looking for, all the different types of implants, and not just that, but they continue to bring and they listen.
yeah,
There's companies out there for You know what companies I'm talking. For years, I kept telling them, your
Yeah.
handles for the abutments are too
Was it?
long. And you try to put them
Yeah.
in the mouth and they don't fit. It only took for me to tell SIN that once. Within a few months, they had made shorter handles. So it's good when you have companies that listen.
Yeah, we'll talk about SIN real quick. A disclosure. I'm a SIN 360 ambassador, as
Me
obviously
too.
you have the scrubs on. How was Paraguay?
Uruguay.
Uruguay. How was that?
Beautiful country. It was beautiful. But what I would recommend anybody that wants to visit Uruguay, I had to fly San Antonio to Houston, Houston, Panama, Panama, Uruguay. There's very few flights from the U.S. straight to
Yeah.
Uruguay, but right next to Uruguay is Buenos Aires, Argentina. So if you fly to Buenos Aires, all you have to do is take a 1 hour plane, or you take a ferry and you go to Uruguay. Very, very beautiful country. Went to Punta del Este, a city that's about an hour, hour and a half east of Montevideo, and
Mhm.
it was the cleanest, safest city that I have been in South America.
Beautiful. I was actually asked to go there too, but I was a little too late. My wife and I went to St. Martin, St. Bart's instead a couple weeks ago. Sorry I couldn't be there with you, buddy.
Yeah, water was a little bit too cold down there. It's they were just finishing their winter. They're about to start their summer down there.
Ah,
And interesting fact about that town, Punta del Este, it has about 12,000 people that live in it, but it has a huge number of buildings and apartments and condos. In the summer, which is starting now, the population goes from 12,000 to between 3 to 400,000 people.
no kidding. Everyone
Yeah,
just comes out of the woodwork,
snowbirds.
huh?
Yep.
Yeah, gorgeous. I want to say this, okay? Little shout out because implants are important, okay? And Patrick, you don't owe me anything for this one, all right? Or maybe Juan's going to charge you, but you want to talk about this? Have you
Oh,
done?
that
You've
kid
done
is
these?
awesome. That kid is awesome. That kid, it has everything to place an Versailles implant. It's just like the name says, very versatile implant, where you can do short implants, long implants. You can do
Yeah,
everything with that
you got
kid.
the long kit.
But hang in there. Wait until my kit comes out.
I can't wait to see it. But the Versalis implant, I'm getting exceptional torque with this easy. And what I love
Yes,
about that is, you know, a skilled or experienced implant doctor, surgeon can probably get good torque with an average implant. But it makes it so much nicer to have this kind of peace of mind. I get great torque, like 60 all over. But what I like about it is that basic beginner doc has an easier time adapting and getting torque. Do
yes,
you find that?
yes. Yeah, absolutely. Well, the Epicode is their all other implant that they have, and this is not replacing the Epicode. But what I've found working with many practitioners is that if you don't have a lot of experience, the Epicode was a much harder implant and to use. So with this one, it's going to make it a lot easier. And then the Epicode will still be there, but I can see the Versailles being a more common implant because of its ease of use.
Oh, I fully agree. I think when I'm teaching Versalis because I know that every beginner doc can probably get it a lot easier, a lot quicker. It's much more forgiving, easier to place.
Yeah,
Um,
absolutely. And the beauty also is that all their implants, whether it's a Zygo, the pterygoid one, long implant, short implant, and all the implants have the same connection. That you use the same abutment for all of the same multi-unit abutment.
a lot of people look up to you. You're an educator and a mentor to many, many. I know you're still traveling and helping other people out in their offices for at least a short period of time. Is that right?
Man, I'm booked all the way to the end
Oh,
of
we're
the
not
year.
doing that. Okay.
I said I'm not gonna go anywhere in December, and I already have 4 places to go.
Well, we're one. Okay, we're one. You're
Yeah,
going to
no,
be
you're
here.
one, and there's three more. Yeah, and then if you want to take a takeaway, okay, I've recently lost two friends in the last two months, and if you're gonna take something, it's like life is short. Enjoy life, live life, and always understand this. People lose track of this. You can
Yeah.
always make more money, but you cannot make more time. Okay,
Yeah.
so you know, time, they say time is money. No, there's no amount of money that can buy you time. When you lose the time, you're done with the time.
Yeah.
You cannot bring that back.
Amen. Amen, brother. And with that, I want to thank you for spending your time with us. December 12th through 14th, we've got cadavers. Sam Jarek, did I tell you Sam's going to join us?
Yeah, no, I love
Everybody?
Sam. It's gonna be
Hello?
great to see him. Last time I saw him was when Athena surprised me having him in California.
Yeah,
He's just such a good guy, such a funny, gentleman and a happy guy, a very happy guy.
I love Sam. Sam and I have a connection because I bought my practice from Truman Baxter, who's an old grand godfather of implants, and he bought his practice from Joe Littlejohn. Truman and Joe Littlejohn were best friends, so we got something in common. Truman taught me subperiosteals. Sam learned subs from Joe Littlejohn, and I do subs, but Sam does a lot more than me. So I feel like the subperiosteal implant is obviously the original patient specific, blah blah blah,
Mhm.
and it's a part of remote anchorage. It's a part
Yeah.
of remote anchorage, right? Atrophic arches. So that's why
Oh, yeah,
Sam's
it's
going to be with
coming
us.
back with luckily with advances in technology and materials, it's coming back, and it's going to take some time to perfect it. But Sam has cases that he showed me a case that I think has been there for like 26 years with just a little exposure in the lingual part of the mandible, but no issues whatsoever. And
Yeah,
I saw a lady in private practice that had a maxillary one that has been there for 22 years, a couple of exposures and she had it cleaned. If I think it's now with the better techniques and materials, if properly done and good patient selection, I think
yeah.
there's going to be a good promising future.
First thing Truman taught me about subperiosteal implants is patient selection, patient selection, patient selection. And honestly, I've only done them on the mandible opposing a denture until recently, where I do them on a mandible opposing like pterygoid quad zygo case. We'll see how that turns out. Um, I'm still uncertain how I feel about the maxilla, but I think we're going to have to go there eventually. I mean, there's going to be
Yeah,
patients that need it.
I've been talking to some guys from Portugal that I'd met in Madrid, and 3 years ago when I met them in Madrid, they told me they were having a lot of issues and a lot of exposures and issues. Last time I saw him or talked to him a few months ago, he told me they were seeing a lot less problems.
Good. Well, I'd love to get more on that later and find out what the secret is on the maxilla then, for sure. Because I'm definitely a little gun shy about it. But again, I think it's going to be coming for sure. So anyway, yeah. The last thing I want to say for the listeners out there, we're filling up January's Module 1, Dr. Godarzi, who nobody knows, Dr. Athena Godarzi. It's Dr. Athena is going to be coming and being our co-faculty there, also with Dr. Brandon Coford of Smart Onyx, because we have to teach you analog workflow, obviously. And they have a lot of digital capabilities in Smart Onyx as well. So my last little shout out for the night. Juan, buddy, it's good to see you doing well. I've never seen you smiling so much and being so
Life
happy.
is good, man.
I've never seen you spending so much time with your family. I'm not saying you didn't before, but I mean you're posting it now at least. I don't know. It looks great.
I always try to, since I travel so much, when I'm home, I try to make the time count.
Oh, I got to do one other thing. Okay, wait, I got to do two other things for those out there. Okay, one, can you tell me who this guy is?
Yeah, that's me when I was in the military. I had to shave every weekend. First every day, and then now every weekend. You know, uh, I've asked a lot of people, should I shave? And they're like, no. I think my wife likes it because she thinks I'm somebody else.
Yeah, I tell you, you look. I like the way you look now. I think you look smarter, more
Frankly,
handsomer.
I started doing it out of laziness. I got tired of having to shave every single time. Yeah, look at that.
Hey, that's not
Who's
fair.
that
What are
kid?
you, Evan? What the hell are you doing up there? Get off the computer. That's me. That's 2006, probably 5 or 6. I took a professional photograph in my living room. All right, get that
Ah,
out of here. Hey, one more thing. I got to show you something. Brecken, my boy, baby Brecken, turned 7 months old yesterday. Check this out. Hang on.
look at that.
Check it out.
Yeah, man, they grow fast. You know that. You have your other two.
I'll tell you what, this is the best part. I got the boy's 1923, 7 months, and getting to do it again with Allie has been a real blessing. This has been a lot of fun. Yeah. 7 months old. He'll be walking before he's 12 months.
Oh yeah, he's
Yeah.
almost. He's trying to. He's trying hard.
Yeah. That's cool, man. Well, I'm glad. Keep on living the dream. Keep on spending time with your family, man. I can't wait to see you in a few weeks, and
Yeah, a few weeks
thanks
I'll
for
be there.
thanks for joining me, man. Have a great Thanksgiving.
Well, thanks for inviting me, man.
Yeah. We'll be talking soon. All right, everybody. That's it. Thanks for joining us here with the one and only Juan Gonzalez. All right. Peace out. Take care, man. I'll call you on the phone.
Yeah, man.
All right. Take care, bro.